pleasure to invite Dr. C.MURALIDHARAN sir, Secretary of RSSDI Tamil Nadu chapter. He will be speaking on MASLD and diabetes interface. Please welcome Dr. C.MURALIDHARAN sir.
Good morning, friends. Really, it gives me immense pleasure to be with you. And our kudos to the organizing committee, Dr. Asudos and Dr. Pallavi and the entire team for this wonderful conference. And because of these gentlemen, we had a nice darshan with Lord Kasi Viswanathan, and with the prayers, let me start my presentation. MASLD and diabetes interface. So, they have a synergistic bidirectional relationship where each condition worsens the other. T2DM is a major risk factor for MASLD, while MASLD in turn accelerates the progression of diabetes and increase the risk of severe MASLD forms like MASH. What is the connection? Connection is underlying mechanism: insulin resistant, systemic inflammation, and the fatty liver disease, which leads to the complications like CVD and kidney disease. So both these conditions, they influence each other. Diabetes drives the MASLD progression, whereas MASLD increases the diabetes risk. There is a shared pathophysiology strongly linked to metabolic syndrome components such as obesity and insulin resistance. What are the mechanisms of connection? Number one, insulin resistance. Number two, hepatokines. Number three, lipotoxicity. What is a global epidemic? MASLD is a global epidemic. The global prevalence is around 38%. Indian prevalence is also 38%. Even in the pediatric age group, like 35%. And in conditions like obesity and diabetes, there is a higher prevalence of MASLD. It is non-alcoholic fatty liver disease. Now it is metabolic dysfunction associated steatotic liver disease. So NAFLD becomes MASLD. Why? Previously in 1980s, the nomenclature is NAFLD, defined by exclusion of the alcohol use. Now in 2023, the nomenclature is MASLD because it is inclusive, non-stigmatizing, and pathophysiologically it is accurate, and moreover it is supported by 236 experts, 56 country Delphi consensus. Yes, NAFLD to MASLD. Why? Because of the strong association with metabolic disorders. Yes, SLD, steatotic liver disease, more than 5% fat in the liver, plus at least one of the cardiometabolic risk factors like elevated TGL, lower HDL, type 2 DM, or pre-diabetes, or obesity, or high blood pressure. And friends, MASLD prevalence is very high in various metabolic conditions. 7 out of 10 T2DM patients, they have MASLD. Not only T2DM, but also obesity, hypertension, high TG, and metabolic syndrome. In India, higher prevalence of steatosis and fibrosis. 75% prevalence of steatosis and 29% prevalence of liver fibrosis. Across the Indian population, Professor Dr. Mohan et al. Study shows 68% MASLD, 33% fibrosis, and 12% cirrhosis. MAP study by Dr. Mohan et al. It shows based on the CAP score and LSM score, higher prevalence of steatosis across India and fibrosis based on these scores here mentioned. So what is the main important carry-home message here is insulin resistance is a root cause for type 2 DM, fatty liver, and high TGL. So shared pathophysiology. Basic underlying pathology is insulin resistance. It leads to hyperinsulinemia one side and hyperglycemia other side in the background of adipocyte dysfunction, which leads to decreased adiponectins, increased free fatty acid flux, which leads to healthy liver to fatty liver in the background of lipotoxicity, progression to MASH, and which leads to T2DM metabolic syndrome one side, other side end stage liver disease, and environmental factors, genetic predisposition also play a role. Among the genetic factors, one important thing is Indian gene PNPLA3. What is the significance? Even in the normal weight individuals, because of this gene, there is an increased liver fat. So the progression of MASLD to MASH, normal liver, fatty liver with trivial or no inflammation, we call it as MASLD or steatosis. Then progression to MASH or steatohepatitis with a significant inflammation, which leads to cirrhosis, increasing fibrosis leading to cirrhosis and hepatocellular carcinoma. So we all know that MASLD, why we concern this MASLD? Because it leads to CVD and CKD more than that of the liver disease. When there is a MASLD with the insulin resistance, hyperglycemia, oxidative stress, systemic and vascular inflammation, endothelial dysfunction, uncoagulopathy, gut microbiota, which leads to ischemic stroke, PAD, CKD and CHD. So we want to emphasize this liver disease, that is MASLD, not confined to liver. It is a metabolic syndrome, metabolic condition, endocrine organ liver. So maximum significance is development of CKD, CVD. This is a main problem. So because of this, we have to give more focus on this condition. So among the key screening criteria, Indian MASLD consensus, any one of the cardiometabolic risk factors, patient sitting in front of you, either T2DM, a CKD, a PCOS, dyslipidemia, hypertension, obesity, HIV infection, this type of patients when we come across, yes, we can go for MASLD screening among the Indian population. Major clinical practice guidelines, they all recommend either type 2 diabetes mellitus or obesity plus more than one cardiometabolic risk factors, or even type 1 diabetes with obesity, you can go for workup of MASLD. Yes, a person sitting in front of you with the type 2 diabetes mellitus, how will you evaluate MASLD? Yes, the patient sitting in front of you, his liver enzyme ALT or ultrasound is abnormal. Then if this type of patients, you have to go for assessment of fibrosis by MR elastography or transient elastography or fibrosis biomarker panels. What do you derive? When there is advanced fibrosis, you have to refer to hepatologist. When there is no advanced fibrosis, you have to go for periodic evaluation. When it is indeterminate, refer to hepatologist, and you can go for liver biopsy, and if there is absence of NaSH, you have to go for a periodic evaluation. Definite NASH, then you have to refer to the hepatologist. And one more set of patients, higher risk of patients, SGLT2, that is ALT is normal, ultrasound is normal, but high risk patient, long-standing type 2 diabetic population, evidence of steatosis, HbA1c more than 8.5%, TGL more than 250 milligram, these patients also you have to evaluate. So hepatic steatosis assessment, ultrasound imaging, one. A limitation is if the steatosis is less than 30% and severe obesity, it is not useful. What is a simple, very, very simple methodology is fibrosis 4 index. It is bedside testing. Fibrosis 4 index is a simple, highly sensitive, accurate and cost-effective test to evaluate presence of fibrosis in the liver. But elderly population, you have to be very careful because they over predict. And FIB4, fibrosis 4, directly proportional to liver events, CV events and all-cause mortality. So elastography, we used to call it as a fibroscan. Fibroscan is the name of the company. Elastography is a test that is vibration controlled transient elastography. The technology is liver stiffness and controlled attenuation parameters. Application non-invasive quantification of liver fibrosis. Here non-invasive quantification liver steatosis. So how will you manage? Management, this is new terminology, FLA1C, hepatic parameters, glycemic parameters, an amalgamation of hepatic and glycemic goals to address a starting point of T2DM. So management is lifestyle guidelines is very, very important. Diet modification, weight loss. Weight loss is one of the basic important management strategies, and physical activity. Weight loss through the lifestyle modification, even 3% weight loss, there is a steatosis improvement. 5% weight loss, ballooning inflammation improvement. 7% weight loss, you can achieve MAS resolution. More than 10% weight loss, you can achieve fibrosis regression. So treatment options in MASLD MASH. In India, pioglitazone is available, GLP-1 is available, glyphosines are available. All are effective in achieving the improvement in the steatosis. Whereas pioglitazone and GLP-1 they improve the state of hepatitis also, and they improve the reduces the progression of fibrosis. So ADA, it encourages GLP-1 and dual GIP and GLP-1 and pioglitazone for T2DM plus MASLD or MASH. Two more slides. Resmetirom is a drug approved by the US FDA, not available in India, but very costly. It is for NASH and fibrosis. Essence study, semaglutide. Previous speaker, they have gone through GLP-1 extensively, extensive discussion. This semaglutide and tirzepatide very, very effective in NASH and fibrosis. This one is decrease in the our saroglitazar, Indian drug, approved by Indian formulation, Indian guidelines, everything for this MASLD and NASH. With saroglitazar, you can achieve a decrease in the NAFLD activity score more than 2 in more than 52% of the patients without worsening of the fibrosis. So last two slides. MASLD expert consensus from Indian diabetologist perspective. Important 5 points. Weight loss is associated with reversal of steatosis and regression of steatohepatitis. Resmetirom approved by the FDA for NASH with fibrosis, but it does not target the insulin resistance. Saroglitazar are approved in India by DCGI for MASLD and non-cirrhotic MASH. GLP-1, RA, pioglitazone, glyphosines, they are off-label indication for MASLD. Vitamin E, Woodca, omega-3 fatty acids, silymarin and orlistat, no supportive evidence for continued use in MASLD and MASH. Root cause for MASLD is insulin resistance. Diet and lifestyle remain the cornerstone of the treatment. Weight loss is a key in any stage of management of MASLD. MASH is a more severe and progressive. FIB4 index is using the CPC and LFT is simple screening tool. Fibroscan and VCTE is a good secondary assessment tool. So take home message is, MASLD is not just a liver disease, not a liver issue. It is a metabolic, systemic condition deeply entwined with the type 2 diabetes mellitus. Liver is an endocrine organ. As a diabetologist, as a healthcare professional, we are in a unique position to screen, identify, and intervene early. Understanding the evolving nomenclature, leveraging therapies like pioglitazone, GLP-1 RA, and glyphosine, they offer a dual advantage, improving the glycemic control and reversing the fatty liver pathology. So, liver matters. Treating it means treating diabetes at the root level. Thank you very much for the patient listening. This is a big topic. Time is given only 15 minutes, so I had to rush it. Thank you.
The most effective things are to ask the patient to exercise regularly and to lose weight and also control the eating. Now, as far as I understand, the medication like pioglitazone, SGLT2 inhibitors, metformin, and maybe tirzepatide, they are off-label treatment. We don't know for certain whether they are going to have any morbidity or mortality benefits. How far would you go ahead and ask them to undergo bariatric surgery if the body measurements so indicate? Because liver cirrhosis is a potentially fatal disease.
Yes, sir. Yes, sir. Lifestyle modification, really it is the toughest thing even for the doctors and for the patient. Education is main role. We need to sit with the patient, educate and tell the patient that if you lose minimum 3% of the weight, there is a reversal of the steatosis, and tell the patient that type 2 diabetes mellitus is a silent disease. And nowadays obesity, patient they don't understand the complication behind the obesity, and fatty liver is a new concept we have been talking about for the last 3, 4, 5 years. Really the educated patient, even the uneducated patient, when we sit with the patient, tell the patient, modify the diet, small changes in the diet, not the big changes. We have to recall the diet of the particular patient, available things in the particular area, without costing much. Small changes if we tell them, they are ready to follow. They follow the small changes with the 3 to 6 months. There is a reduction in the 3 to 5% weight, we are able to achieve it. And when we go for medications, even I was talking about the SGLT2 inhibitor, off-label indication, but it is a DAPA and EMPA, they have wonderful medicines. For many patients, it offers a cardiorenal protection. With SGLT2 inhibitor, we are able to achieve the steatosis resolution 1. Moreover, there is some study I went through the last month, DAPA glyphosine. One study shows that there is a improvement in there is a resolution of the NASH also. So this DAPA and empagliflozin, one drug with multiple benefits. So type 2 diabetic patient with MASLD, for achieving the glycemic benefit as well as the cardiorenal protection, we can encourage DAPA and EMPA. Plus this glyphosine, they offer the weight reduction also. For many patients, we can see 4 to 5 kilograms, 6 kilograms weight reduction with the SGLT2 inhibitor and affordable. Previously, the originator molecules were costly. Now, Indian standard medicines are very affordable medicines. And GLP-1, now March 21st, after March 21st, many companies, more than 100 Indian companies, they come out with national brands with so much of reduction in the price. And finally, you were talking about the bariatric surgery. Yes, for Indian people, Indian recommendation, more than BMI 30 or 27.5 with comorbid conditions, we can encourage. But bariatric surgery is highly effective. in achieving the steatosis, mass resolution, and fibrosis reversal. Even because of this large amount of benefits, only one thing we need to educate the patient, convince the patient. Post-operatively, another 6 to 12 months, so many behavioral modifications we have to teach. So, really eligible patient, affordable patient, and the BMA and comorbid conditions, and good setup is that we can encourage to go for bariatric surgery.
Dr. Sir, there was a time when I was suffering from
Pioglitazone for obese, I don't advise, sir. Pioglitazone, it has shown steatosis improvement in the steatosis, improvement in the steatohepatitis, and some improvement in the regression of the fibrosis.
My question is, all these drugs are recommended in the patients who are non-diabetic.
Non-diabetic, we don't advise.
So only if the patient is that.
Actually, we are running out of time. Please help us, sir. Actually, there are so many persons to talk, and we have inaugural program. Sorry to do that. Actually, it is very interesting thing that we are having discussion, but we have to move forward. Thank you, sir, very much, sir.